I'm Dr. Don Buford. Welcome to the Global Summit. Come on into Texas Orthobiologics. Let's have a chat. All right, let's get going. All right, so let's get going. I am really excited to be a part of this Global Summit. Thank you so much to my friends Ryan and Colin for the invitation to give this kickoff keynote address. The title of this presentation is Biologics and Orthopedics, Redefining How We Treat Degeneration and Injury. I'm going to cover a lot of ground in the next 30 minutes, but I'm going to start with a question. Would any of you be interested in a new type of orthopedic treatment that has a 74% response rate, a 91% patient satisfaction rate, and a 0.07 complication rate, while at the same time has no significant downtime for the patient? It's not a surgical procedure. It doesn't involve narcotics. And on top of that, it's anabolic instead of catabolic. What if I had 40,000 documented patients to back this up? Would that be enough? We're going to explore the answer to that question over the next 30 minutes. So in the next 30 minutes, I'm going to focus on a lot of concepts that have a common denominator. They interface with our own human biology to get results. This will be an evidence-driven discussion. There's 3 slides full of references at the very end of this presentation, so make sure you get the handout. And I want to encourage every clinician that cares for orthopedic patients to redefine how they're currently treating degeneration and injury in orthopedics. This is where you can get the handout. You can use the QR code, which will be on a couple slides, or even faster, you can type in buford.info/2025 Global Summit into any internet browser, and that will take you to our free handout. Why does this topic matter? Well, there's a rising burden of musculoskeletal disease in the country. Last year, 4.2 million people turned 65. That's more than 11,000 a day turning age 65 last year. We have an orthopedic treatment gap, and there's lots of ways to define it. But in general, patients that have chronic pain and dysfunction but are not surgical candidates are patients that are in this orthopedic treatment gap. Patients have injuries that take a long time to heal or don't heal at all, or the solution doesn't restore the same function. So what good is that? We can and should and will do better for these patients. So obviously, with Walmart, buying gold is designed to be easy. It's designed to be quick. Even though it's an expensive product, it's designed to be something that doesn't require a lot of thought. And that mirrors the current problem we have with our orthopedic gold standard. We use serial corticosteroids for chronic degenerative conditions. We do blind injections. We're not using ultrasound routinely. We're not even routinely teaching ultrasound in orthopedic residencies and fellowships. Radiographs are overused to guide soft tissue and biologic decision-making. We can't see the soft tissues on a radiograph, obviously, or on a fluoroscopic image. Waiting for surgery is the basic default strategy. How many patients come to see you and they've been told, come back when you're ready for surgery? That is no longer an acceptable thing to tell a patient when we have other proven treatment options. In terms of pain, across specialties, we have a dysfunctional ablative approach to the biology of pain. Whether it's an ablation, a cryoablation, a nerve transection, or just a nerve block, our goal is, if it hurts, let's just block the signal, not how do we go upstream and treat the pathology that's causing that signal. Because until relatively recently in orthopedics, frankly, we haven't really had good evidence-based options, but now we do. What can biologics actually do? They modulate inflammation and vascularity. They shift macrophage phenotype towards the reparative M2 phenotype. They improve the local tissue microenvironment. They support tendon and cartilage health and strength. And they enable biologic remodeling that our body really wants to do anyway. We're just giving it extra juice, if you will, to get that done. Let's talk briefly about the PRP mechanism of action. Platelet granules release multiple proteins and cytokines. Included amongst these are platelet-derived growth factor, transforming growth factor beta, vascular endothelial growth factor, insulin-like growth factor 1. PRP stimulates the broad class of fibroblasts, which includes tenocytes, stimulates chondrocyte activity as well. So with this one treatment modality, this one biologic drug, we are getting vast, multifaceted effects in human biology. We have to focus on how do we quantify this drug? And right now, the best quantification that correlates to outcome is the platelet dose. And that formula is relatively simple. Platelet dose is simply the volume of the PRP times the platelet concentration in the PRP. Of course, there are other components in PRP, and although we don't have a solid understanding of which is more important, which ratio may be more important, some of these other cellular factors include monocytes, lymphocytes. Again, the ratio may be important. And so there's plenty of things still to be worked out by wizards and clinicians that are interested in how this actually works and digging underneath the hood to seeing if we can make a better biologic treatment. In knee osteoarthritis, we have multiple studies that show that PRP is really the best thing we can do for patients looking to avoid surgery. It's also the best thing we can do for patients looking for a disease-modifying non-surgical intervention. We have multiple level 1 studies now that show that platelet-rich plasma exceeds hyaluronic acid any time point from 3 through 12 months. And that's been shown, actually, it's well over 18 randomized controlled trials, but that's just a solid number that you can use when you're discussing this with patients and other clinicians. PRP results are best when they're used for patients with mild to moderate osteoarthritis. So this would be your Kellgren-Lawrence grade 2 or grade 3 diagnosed patients. PRP has an exceedingly strong safety record. Typically, protocols support using 1 to 3 injections. There's a study published in 2022 by Dr. Chu. That was a 3-injection protocol, 1 injection a week for 3 weeks. And of course, there was a single injection study published by Dr. Bonsall in 21, and that was a single higher dose injection. What seems to hold true across continents, across researchers, is this concept of not just the single injection dose, but the total dose. They are surprisingly similar in the 2 studies that are listed. Dr. Bonsall's total dose was 10 billion platelets in a single injection versus Dr. Chu's protocol of 3 injections, where each injection was 4.2 billion platelets, making his total dose a little bit over 12 billion platelets. So when you give your injections weekly, it does seem that you can add the platelet dose together to get a total dose. And when you do that, these total doses that are measured in the teens or maybe in the 20s seem to give a higher percentage of patients a reasonable outcome for a longer period of time. We don't really have the evidence to support the concept that doing injections monthly or beyond can really be added together to get to a total dose. Right now, the best protocols that are multi-injection protocols are weekly protocols. And when you do these injections weekly, it does seem appropriate to add those dosing numbers together to get to a total dose. I do need to mention, though, that it seems to be possible to be too low. We've got 2 studies, 2 well-done level 1 studies in the literature. One is called the PEAK, P-E-A-K trial, and the other is called the RESTORE trial. Both of those had doses under 2.5 billion platelets, certainly under 3 billion platelets per injection. And those injections were done weekly for 3 weeks. Both of those studies showed no significant benefit for patients with knee OA, despite having total doses that were probably somewhere in the 6 billion to 7 or 8 billion range when you add up all 3 injections. So there does seem to be a dose below which it doesn't really lead to the outcomes that we're desiring. We have a ton of registry and published data now suggesting that the durability of a PRP drug for knee OA is beyond 1 year, especially with total doses above 10 billion. It doesn't mean that you can't have a successful outcome with a lower total dose, but my contention and my opinion is that with a higher total dose, we're going to capture a higher percentage of people, And that higher percentage of people that do well will do well on average for longer. In my opinion, is based on registry data across thousands of PRP applications for knee OA, not just my own practice. Let's talk about PRP evidence for tendinopathy. The strongest evidence right now is for lateral epicondylitis, and this goes all the way back, oh gosh, 11 or 12 years now, back to early work by authors like Alan Mishra, who authored one of the earliest orthopedic surgeon-led investigations of PRP for lateral epicondylitis. It was a great level 2 study. And ever since Dr. Mishra's study was published in 2014, we've continued to refine what we know about PRP dosing for lateral tendinopathy, including using ultrasound guidance for better outcomes. Using PRP can benefit patients with patellar and gluteal tendinopathy as well. I would have to add here that patients with rotator cuff tendinopathy can also benefit from well-done PRP injection protocols too. Most of the higher level studies that document the doses show that there's better durability using PRP versus corticosteroid. In terms of soft tissue applications, one of the studies that our group published documented that you want to be on the upside of 3.5 billion platelets and ideally closer to 4 to 5 billion platelets for most soft tissue applications to stimulate the biologic response that we're all looking for. These procedures require ultrasound guidance, and I can't wait to finish this talk and stick around the rest of the day and hear about the latest, greatest things using ultrasound as a diagnostic and procedure tool. These procedures need to be combined with structured rehab depending on the pathology being treated as well. We can't ever forget that. So let's talk about bone marrow concentrate now. Bone marrow concentrate contains mesenchymal stem cells. Don't forget it also contains hematopoietic stem cells, contains cytokines, and it contains other proteins. Why is it important to remember the hematopoietic stem cells? Well, it's important because immature stem cells, whether they're mesenchymal or hematopoietic, tend to make the same cytokines and proteins and export them. So you can count the less mature hematopoietic stem cells before they've terminally differentiated into something in the hematopoietic line as warriors in this biologic battle that we're about to instigate by doing these injections. Our bone marrow plasma has high levels of IRAP. It also has high levels of alpha-2 macroglobulin. Both of these larger proteins are well-known biologic players, and there are certain advantages to using bone marrow plasma and manipulating it in certain ways that can give us a very anti-inflammatory biologic drug along with having some cellular content. Early osteoarthritis and focal defects respond well to bone marrow concentrate injections. We have to remember that the response is not just based on cellular content, though. I would argue that there are so many other biologically active things in bone marrow plasma that just intuitively it makes sense that the responses that we're seeing that last, in some cases, over a decade can't just be from a very short-term injection with a cellular product. Bone marrow concentrate is useful in biologic surgical augmentation procedures. Prospective studies have shown 2 to 4 year durability for intra-articular injections using bone marrow concentrate for degenerative joint disease, for example. There are intraosseous studies showing that using bone marrow concentrate can give outcomes that are durable beyond a decade even. One of the things that is attractive for using bone marrow concentrate as a biologic is that it's autologous, which means relatively low cost compared to a drug product that comes from a company and has all of the research and development costs and all of the patent costs associated with it. It's a same-day preparation in instances where we're not culturing. And so far, a lot of our published literature suggests that a lot of these same-day bone marrow concentrate procedures can be highly effective as long as we pick our patients properly and do the procedures well using ultrasound guidance. So let's talk about adipose-derived biologics. These are still autologous things that we're talking about. In the United States, we're primarily talking about MFAT because we are still restricted from using enzymatic digestion of adipose tissue. So we are using MFAT. It does provide a scaffold. It provides cytokines. We have a growing base of literature documenting that using MFAT can give patients symptomatic relief and functional improvement when they have osteoarthritis. MFAT can be a great soft tissue augmentation as long as you're using a device that is cleared FDA 510(k), then you are using a device that is legal to be on the market. Microfat performs a structural and an anti-inflammatory role. And another thing that's nice about MFAT is it can be used as a combination therapy in complex cases where you may want to augment a soft tissue defect along with using a high-dose PRP injection for other indications or what have you. So again, the research, the clinical research and the literature continues to grow in illustrating ways that we can use MFAT for our patients' benefit. So now we're going to change gears and talk about what's primarily an allograft biologic. We're going to talk about exosomes. These are typically small cell-free vesicles with signaling molecules inside of them. They are released by cells and picked up by cells, and there's signals that are passed in between. They can have potent immunomodulatory effects. The early clinical data, and I stress early in that sense, the early clinical data is encouraging. These are typically allograft sourced from cell cultures, or potentially there is a new autologous process with a third PRP spin combined with polyethylene glycol and dextran that can capture exosomes from our own autologous plasma. And so as soon as that gets a 510(k) clearance, that may be another avenue for clinical research to see if we can supercharge our PRP with this super shot technique. The current USA regulatory environment is restrictive. Exosomes are classified as unapproved drugs in orthopedics. There is not an on-label reason that we can use exosomes currently, which means that unless we're part of an IND study or an investigational device study, that we currently are restricted from using exosomes. So the next topic I want to cover is something I'm sure that we've all heard of. I'm sure that we're all being just, leveled with questions about peptides in our clinical practices every day, every week. And there's a couple things I'd like to state that are opinion-based, but these opinions are based on readily verifiable facts from the FDA, from the regulatory authority in the United States, who has the final say. First, what are we talking about? Peptides are short chains of amino acids with biologically active effects. There is not a question that they are biologically active. The common peptides talked about within orthopedic applications are BP 157 and TB 500. They do not have any regulatory clearance to be used in humans in the United States currently. There is one peptide that I love, and I recommend it for the right indications. Back in the day, my friends used it in sports. It has saved about 1 billion lives since 1922. Anybody know what I'm heading towards here? The peptide is insulin. And the reason I bring it up is because peptides by nature are not bad. Peptides have been around for a long time, and we know that they can have significant effects on human biology. In addition to insulin, we have the weight loss peptides like semaglutide, Mounjaro, Wegovy. We just don't have FDA clearance for the ones that are being talked about as potentially beneficial in orthopedics. And so that's a problem. We cannot use those off-label if there is no on-label indication. So what's happening? People are talking about this on podcasts, on Facebook, on Instagram, on TikTok, in the gym, and people are going to websites like the one shown up here on the left where they can buy a bottle that has BP 157 and TB 500 in one vial, multi-use vial, and the cost is like $130. So very, very low bar, not very expensive for a patient to try if they've been told that, I've used this for the last 6 months and look at me. So it's a low bar. The problem is on that same vial, it's going to say for experimental use only, not for sales and use in humans. The quality of what's in that vial is unknown because it's not regulated like a drug. And so that is the fear of people going out and injecting themselves with something they buy off the internet from essentially an unknown source. And here's really the facts. Peptides are not approved as a drug. They're not approved as a biologic. They're not approved as a dietary supplement. I've seen some supplement pills that are purported to have peptides in them. There's no approval for that either. They're not approved for any medical condition, and they're not in any FDA database of cleared therapeutics. Right now, we have no FDA authorized investigational new drug study for BP157. So if somebody tells you you can just be part of this study, it doesn't exist. And all of these things are searchable online. There are no current legitimate human clinical trials in the US that I'm aware of. Happy to update this if somebody has better information. Everything quoted online currently is rodent or animal data or unregulated anecdotal use. The FDA categorizes it as an unapproved research chemical. And so as a result, compounding pharmacies are also prohibited from compounding it legally under 503A or 503B. And what that really means is that these peptides, BP157, TB500 as two examples, are not on the FDA bulk ingredients list. They don't have USP monographs, and they're not part of any approved drug product. And so right now, compounding pharmacies are in an extremely gray, if not very black zone, if they are compounding those two compounds. Additionally, if you're taking care of athletes, high-level athletes, WADA, the World Anti-Doping Association, currently bans BPC 157 because it's under a non-approved substance list. So lots of reasons to be optimistic, a lot of reasons not to use it right now clinically unless you cross your T's, dot your I's, and you start that FDA study if you're going to be doing this in the United States. And so now we're going to talk about one of my buddies here and one of his pet projects. And of course, I'm talking about Scott Sigman, who's an orthopedic surgeon that you see there in the middle of the screen. Laser is simply light energy delivered at specific wavelengths. It stimulates mitochondria. A lot of what we're doing ends up going through this common mitochondrial pathway, if you haven't figured that out yet, but stimulates mitochondrial ATP production, increases circulation. Laser reduces inflammation, decreases nerve pain signals. And so Dr. Sigman, as you see here, is the founder of a franchise called Ortho Laser. They use this MLS laser that you see in the picture, and it is a class 4 cold laser. It is ideal as an adjunct in regenerative orthopedics. And the reason why is because it enhances the healing milieu, it reduces inflammation, it supports with the repair environment, and we have ongoing research, both clinically and in registries, that are showing that adding this treatment modality along with our biologic injections really supercharges the results. And so as we continue to fine-tune our protocols, this is one of the modalities that a lot of us will probably be taking advantage of more and more once we can see the results. Let's talk a little bit about shockwave. So there's two broad categories, focused versus non-focused. You can see the Curomedics or storage device on the left, which can be one of the more focused examples versus something like SoftWave on the right, which is more of a non-focused example. ESWT increases MSC recruitment. It enhances growth factor release. It's been shown to support collagen organization. These are all good things for healing, right? And it improves cartilage regeneration in conjunction with biologics. Now, where do we have the strongest clinical synergies in terms of the published literature? It's probably strongest with plantar fasciitis, lateral tendinopathy, and Achilles tendinopathy. And especially with focused shockwave, we're creating this mechanotransductive effect to stimulate this healing response and create these other responses that are listed on this slide. This is another energy-based way to try and stimulate our human biology. This is one of the new kids on the block. This is called sustained acoustic medicine. And what an amazing option it is for our patients. It is a long duration wearable ultrasound that provides continuous mechanotransductive stimulation without pain. You can't feel it. It reduces pain and inflammation. It increases mitochondrial activity. There's that word again. It enhances soft tissue healing. It improves microcirculation, and it can be used daily. So when you dig behind the scenes a little bit, what you discover is that when you use two of these adhesive patches with an ultrasound generator, you're delivering about 1.3 watts of energy up to 10 centimeters deep into the human body. You can wear this up to 4 hours a day. It's FDA cleared for soft tissue healing applications, and there have been over 30 studies using sustained acoustic medicine, or SAM for short. It is so well established that Medicare covers this therapy for patients with knee OA. It's kind of a head scratcher to me why Medicare covers this for knee OA and doesn't cover PRP that has probably 80 studies. The FDA right now is currently constructed to be able to handle this type of application compared to a biologic like PRP. That's the only thing I can think of. So what is the role of ultrasound imaging guidance, especially as we relate it to biologic procedures? Ultrasound turns blind injections into precision procedures, which improves accuracy, improves outcomes, and reduces risk. Ultrasound allows for diagnosis and treatment in one step at the same visit, if necessary, all without radiation. In my experience, and I know experience of many, many others that are taking part in this global summit, ultrasound improves patients' understanding, improves their confidence and compliance, reduces procedure anxiety, and ultimately improves the doctor-patient relationship. And now I'm going to talk about something that happens to still be near and dear to my heart, which is orthopedic surgery, and how we're even using biologics in surgery now. Biologics can improve surgical outcomes. And two examples where that's been shown is with rotator cuff surgery and with meniscus repair. Biologics can support cartilage-based procedures where we're trying to help people with condylar defects, osteochondral lesions, things like that. A biologic like bone marrow concentrate can essentially cure a marrow disease like avascular necrosis if you catch it before there's been significant structural changes. And so here, if we look at some of the many recent orthopedic surgical advances, not only are we using injectable biologics, but orthopedic surgeons and engineers are looking at using human biology in addition or in the design construct of these implants that we're using. So on the left, this is an implant called BioBrace, for example. BioBrace is made of bovine collagen. So I want to go over some recent orthopedic surgical advances because there are some things here that you may not know, and I just want to, open up uh, this summit to some of the amazing things that are happening within my specialty of orthopedic surgery. BioBrace came out, about 4 years ago now, and it is an implant that's made of bovine cow collagen. It is obviously sterilized, and it's also impregnated with PLLA fibers that gives it structural strength at time zero. So BioBrace is cleared for any place in the human body where you need soft tissue augmentation. And the really cool thing about BioBrace and the reason why it's so novel in orthopedic surgery is it also will absorb a liquid. And so what you see below is me soaking the BioBrace with bone marrow concentrate before sewing it on top of a massive rotator cuff tear. And so now we have a chance to use all of the tools, right? We can use bone marrow concentrate. I can put some of that bone marrow concentrate in the greater tuberosity, like Dr. Hernigau showed was a useful thing to do. I can use an implant that is strong enough for me to suture and yet goes away in about 2 years. That would be this BioBrace. And now I can maximize my biologic treatment in addition to providing the surgical construct needed for strength to get this to heal. The second thing I'd like to talk about would be here, MACI. So MACI is a procedure where you take a piece of cartilage from a patient, you send it to a lab where they culture it, and then they send it back to you already impregnated into a collagen membrane. And what's really cool about MACI now, it's gone through 3 or 4 generations over the years, is now when it comes back to you to then take into surgery, you can do this arthroscopically. And so MACI used to be a procedure that required an incision. It was a much more involved procedure, but now they've got it down to where you do that initial chondrocyte harvest, you culture the patient's own chondrocytes, it gets impregnated onto this membrane, and now it's great for chondral defects. The knock on MACI potentially would be the cost. It's not a very cheap procedure, as you would imagine. It involves culturing. It involves a two-stage procedure, the initial surgery for the harvest, the second surgery for implantation. So as we get even better at this, having an autologous option that accomplishes the same thing would not only be more cost effective, but may give a better longer term outcome. We'll see. Jury's still out on that. So let's talk about Agili C. This is just a plug that you see there. It's calcium aragonate, and you put this into an area of the bone or of the joint where there's a condylar defect or an osteochondral defect. There's nothing else on it. It's not seeded with cells, but you press fit this into that hole, and it has been clinically shown to regrow cartilage. Okay. And that's partly because the porosity matches the porosity of cancellous bone. So it's very osteoinductive. But even more than that, at the interface between the cartilage and the subchondral bone, it is designed to stimulate chondrocyte um, implantation and chondrocyte growth. And so when you look at the studies and the histology 6 months to a year later, all you did was put in this plug that looked like a little piece of chalk, and lo and behold, later, the cartilage layer is healed. It is an incredible advance in orthopedics that allows us to deal with cartilage injuries. And this is without PRP, without adipose, without bone marrow concentrate. So, of course, with my brain, I'm thinking, I wonder if we can make it even better if we add something autologous to that that's cellular in nature. And that really hasn't been done. And based on their histology that you see here, right now, they're getting great results out to 4 years without any additional therapies. I want to talk about the design of this suture anchor. This has come a long way. You know, when I first started, we really just had one suture anchor in orthopedics, at least in the shoulder. And now we have an anchor design called the helicoil, and it's a screw-in anchor, but the threads are open. And then we put in this screw that not only is absorbable over time, but it's open. So when you put this down into the marrow can soak and come out through the screw. And then it can come into the subacromial space in this example, which is a rotator cuff repair. And so now if you go back and if you're familiar with Dr. Hernigau's work putting bone marrow concentrate into the greater tuberosity, when we use these anchors, that bone marrow concentrate can come out through these anchors and participate in the healing response right at the enthesis and hopefully stimulate a healing response. And so the engineers are lockstep with the clinical practitioners in trying to harness biology and make it easier for biology to work, all to the benefit of our patients. Registry data. And so this goes back to, would you be interested in a procedure that has a 91% patient satisfaction rate, a 74% treatment responder rate, and the complication rate is 0.07%. If we take that to an entity like the FDA, how could they not be interested in this treatment? And so this gives us a chance to have real world, real time, multi-center outcomes. And if you're not using a registry, whether it's this one or others that are available, then you need to start. That's just the bottom line. If you're going to be doing this more than once a month, you need to use a registry. It is not expensive to do. And throwing your patients into the kitty, if you will, allows all of us to get better. Where can we improve? We can eliminate the overuse of steroid injections. That is something that is easy to put at the number one slot. I would love to see us standardize PRP composition reporting. What do I mean by that? You know, at least tell us the white blood cell count, tell us the monocytes, the granulocytes, the lymphocytes, tell us the volume, tell us the platelet count. That should be at the bare minimum, that should be what we require for papers that are trying to make comments on outcomes from this biologic drug. I just harped on making outcome tracking mandatory. I think we need to do that. I think we need to continue to educate patients in an ethical and as much as an evidence-informed or evidence-based way as possible. We need to continue with indication-specific protocol development. And this is going to be not just specific to a particular drug, but we're seeing the rise of more and more multi-drug protocols. If you count laser as a drug and PRP as a drug and MFAT and CuraWave or SoftWave, Curamedics or SoftWave. So we're going to be looking at protocols where we just want to know what is the best combination of things to do for a person with this problem. And I'm excited to see what the future holds with that development. I think we continue to need increased FDA and FTC regulatory clarity. And in my opinion, I would love to see non-compliance consequences much more severe than they are now. Just getting a letter saying, please stop in 2 weeks has been shown over the last decade to be, sadly, grossly insufficient to change behavior. I would love to advocate for insurance coverage, but only if reimbursement is value-based. What do I mean by that? Patient's value is what we need to base reimbursement on. What kind of quality of life improvement are we giving patients and for how long? Clearly, all of us have patients currently paying cash for this without insurance. If insurance covers it, that doesn't make it less valuable. It just means that insurance should cover part of it because the insurance companies are seeing a value too. They're not paying for a meniscectomy. They're not paying for a joint replacement for 10, 15, 20 years. Okay. And so as long as the insurance companies that start to cover these procedures base it on the value that the patients are receiving and the overall decrease in healthcare costs that we are generating, then I think that would be fair. TRICARE was a good example for 5 years. For PRP for NeoA, TRICARE paid somewhere between $2,000 and $2,500 per injection, and I think they paid for up to 3 injections. So if insurance companies covered PRP at that rate, I think that would be fair. I'm very fearful of what really happens based on my 27 years as a doctor, in that they actually start to cover these procedures and ratchet down the reimbursement so that they can capture all the value. So, my closing message, please continue to be persistent, be curious, be open-minded, and be thoughtful. Biologics equals modern orthopedic medicine. Don't let anybody tell you different. Let's all get better and let's all understand and treat biology and not just anatomy. There's going to be some obstacles, there's going to be some failures. You have to remember that it takes a lot of losses to win. And everybody wants to win until they realize how many losses it takes. And so we need to continue to have thoughtful clinicians pushing the bar, thinking up better and better questions and getting better and better answers to those questions. Let's continue to develop earlier interventions in order to prevent later pain and dysfunction for our patients. So these are my social media contacts where you can reach me. I have to mention the Interventional Orthobiologics Foundation. I'm in my second run as president of the organization, and I am so excited to be able to partner with Toby for the next IOF Max annual meeting, which will be in June. You can find it online. This is my new favorite Dallas Cowboy. May we all possess the same drive to improve as Elijah Clark does, number 38, in this video. Why? Because look what happens. It matters. He creates the fumble that leads to the touchdown. And so if you get knocked down, keep getting up, keep asking questions, stand up there for your patients, and be a voice for biologics. Thank you for your time. 2, 1. Okay, so that's a wrap. Hopefully I accomplished my goal of getting everyone exposed to some of the concepts that we have to deal with when we talk about biologics and orthopedics. And I look forward to listening to the rest of the curriculum.